This program is brought to you by Emory University.
Good morning. This is Mon. It's my privilege to introduce Dr. Adrienne Kovacs, who is the current president of the National Society for Adult Congenital Heart Disease. She's a clinical psychologist and the first non-physician to be a leader of this organization, quite prestigious organization. She earned her PhD in clinical psychology at the University of Memphis, and then completed postdoc fellowships in clinical psychology in Florida and in Toronto. And between 2004 and 2015, she was at the University of Toronto in Canada, and in 2016 moved to Portland and established and directed the behavioral cardiovascular program at the Knight Cardiovascular Institute of Oregon Health and Science University, and then promoted to professor in 2020. Her time is divided between clinical work, program development, and research, and she is quite very well known in the field, has more than 100 peer-reviewed publications, contributed to several position statements for American Heart Association, European Heart Society. She is now back in her hometown of Toronto, Canada, and has quite a variety of interests, including physician well-being and burnout. Dr. Kovacs will be talking to us about some of the challenges, psychological challenges taking care of patients with congenital heart disease. And this is an area that is near and dear to my heart, but I think something that is applicable to all of us who take care of these patients, and maybe the lessons applicable outside of congenital heart disease as well. Dr. Kovacs, thank you so much for joining us today.
Thank you. Thank you very much for that kind introduction. And I appreciate the comments that you just made, because I think that oftentimes we think this kind of information is only a priority to people who are working in specialized adult congenital heart disease or ACHD teams. But what we know is that this information is relevant to all members of a cardiovascular team. So if you work in heart failure or electrophysiology or imaging or acquired heart diseases, or patients are living longer, these people go through the system, inpatient, outpatient. So I think that the information we're talking about today, hopefully most of you will find some relevance in this. And I have no financial conflicts of interest. So let's talk about some learning objectives. So to begin, we'll talk about the what and the why. So the what, I'll describe common psychosocial challenges of adults with congenital heart disease. And I'll also talk a bit about challenges pertaining to the transition from pediatric to adult care and their impact on clinical outcomes. So why people might be particularly concerned about this. But when I give a presentation, it's really important for me to also focus on the how. So we'll talk about how to apply strategies to improve the psychosocial well-being of adults with congenital heart disease within a team-based approach. And I'd like people to leave feeling more confident in their ability to demonstrate communication strategies to improve the psychological care of adults with all forms of cardiovascular disease. So a few questions before we begin. I know that people often begin with case studies, and in my experience, I find that my cardiology colleagues often find it more powerful to think about applying some of these situations to themselves. So have you ever been frustrated by the length of time it takes to get a medical appointment for you or a loved one, or called expecting to get an earlier appointment? Have you ever been frustrated waiting for test results and/or reached out to another health professional to discuss them right away? Have you ever arrived at a medical appointment ready for a thoughtful discussion of your list of questions about your symptoms and treatment or a loved one, and perhaps with articles you've printed from PubMed? And have you ever been sad, worried, frustrated, or angry before or after a medical appointment? And I ask these questions because they highlight that it's not easy being a patient. And how do you think you might react if, or how did you react if one of these things happened to you? You experience significant symptoms with or without clear etiology that interfere with daily activities. At the height of your professional career, you're told that it's time to reduce your work hours or stop working altogether. You realize that your body and your brain will not work like it used to. You're diagnosed with a medical condition with a shortened life expectancy, or you're told you need transplant. Again, I ask these questions because it's helpful to have a bit of context that it is completely understandable to have a psychological reaction to a difficult health situation. So let's move on now and talk about some of the common psychosocial challenges of adults with congenital heart disease. And I used to begin presentations by saying, our ACHD folks face unique challenges, and people would say, well, what is so unique? Isn't it just heart disease? So I do think it's important to distinguish some of the experiences and concerns of people with complex heart disease versus acquired heart disease. So much younger, obviously typical age at diagnosis, which means that people with complex congenital heart disease have lived with this throughout their lives. People with congenital heart disease can have surgeries and interventions as a newborn, childhood, adolescence, adulthood, even the fetal period. Younger age in general, with complex congenital heart disease, average age of death in the 40s, although increasing. We always recommend follow-up at a specialized center. And as a psychologist, I can tell you that the coping focus is different. So when I work with people with acquired heart disease, it's often about recovery, adaptation. So people will say, well, I used to be healthy and now I have this diagnosis. With congenital heart disease, it's very different because the focus is on coping with a lifelong medical condition. Living with congenital heart disease can impact neurodevelopment and psychosocial development. There's an increased risk of parental overprotection. They have to deal with the transition from pediatric to adult care. There can be impact on education, career, family planning. So some of these people are told that it would not be safe for them to have children. Some people are told that wise to consider a job that is not physically demanding because we don't think you'll be able to do it once you get past 20s or 30s. We don't see as many sex differences in rates of mood or anxiety. And another big difference is the public's familiarity with disease. So for older people with acquired heart disease, people know somebody who's had a cardiac event. Oftentimes people with congenital heart disease will say that they don't know anybody else like them. And there was a nice survey of 57 adults with Fontan circulation in Australia and New Zealand. And they included an open-ended question, and they asked them, what is your greatest concern as an individual with a Fontan circulation? And they said it's this fear of death and uncertainty around life expectancy. They wanted to know when the Fontan would fail, how long they had to be normal. And they described how uncertainty means it's difficult to make long-term plans. And I say this because, again, I always say a little bit of empathy goes a long way, but imagining what it will be like to be an adolescent, a young adult, and their main concern has to do with how long they have to be normal and how long they have to live. When we look at outcomes in ACHD, a nice 2018 review demonstrated that across studies, elevated symptoms of depression ranged from 6 to 34%, and elevated symptoms of anxiety range from 34 to 42%. And there's a difference between using surveys and clinical interviews. So surveys is a self-report measure. People circle numbers or put little X's or check marks in to indicate symptoms. It's very different from using clinical interviews methodology, which is what's required to assign a diagnosis. We know that North American studies that have used clinical interviews have found that about a third meet diagnostic criteria for a mood or anxiety disorder. We know also from this research that very few people who have clinically significant psychological distress, meaning they meet diagnostic criteria, receive mental health treatment. And the really unfortunate bit is that there has been almost no increase in integrated mental health care since these studies were published. And, I think that in congenital heart disease, we have made tremendous gains over the past few decades. Many of us still begin our manuscripts saying, as a result of significant improvements in imaging and treatment, the life expectancy is much higher than ever before, and 90% will reach adulthood. And to me, improvements in psychological well-being is one of the new frontiers of what we can do to improve the quality of life of our patients. This is a study from Germany here, and they administered clinical interviews to adults with congenital heart disease, and they compared them to the national sample. And rates of major depressive disorder and generalized anxiety disorder were about 3 times that which we would expect from the general German population. And in terms of the ACHD sample, 48%, almost 1 in 2, met diagnostic criteria for any of the following psychiatric disorders. Again, much higher than in the general population. A study from France, again, they also administered a type of diagnostic clinical interview, and the rate of major depression was over double that, 43% versus 19% in the controls. Again, so it's often difficult to compare to controls, the general population determining, dependent upon how it was assessed. But we know that we more commonly see depression and anxiety in adults with congenital heart disease compared to the general population. And I would also add, for the non-ACHD folks in the audience, we see higher rates in all forms of cardiovascular disease. So post-MI, people with heart failure, people with arrhythmias, people with ICDs, for example, we always see elevated rates of depression and anxiety. And we know that psychological outcomes are greater than depression. So historically, depression has received most of the attention in behavioral cardiology. It's actually not what I see most often clinically. So we did actually a retrospective review looking at who presented to the ACHD psychologist, and that was me. And generalized anxiety, stress, heart health-related anxiety were actually more common than depressed mood, and these obviously were not mutually exclusive. PTSD is interesting because oftentimes at meetings I will see people will stand up and they will say, all of our patients have PTSD, we need to do better by them. And we actually did a study, this was with colleagues in Philadelphia, and we administered surveys to 134 adults with congenital heart disease. And we found that 21% had elevated symptoms on a PTSD checklist. And that is looking at trauma symptoms related to any traumatic incident. And 11%, about 1 in 10, had elevated symptoms on another scale where we asked specifically about stressors and traumatic experiences related to congenital heart disease. And I say that because that's 1 in 10, slightly higher than the general population. And yet, I think it's important to be mindful that people can experience a traumatic experience and not necessarily have PTSD afterwards. As mentioned before, people often come to see me with health anxiety, and I wanted to share a couple lists of potential health-related stressors. And here in this first box here, all adults with heart disease potentially face these stressors. So new or worsening cardiac symptoms. Taking medications can be very, very stressful for some people. Oftentimes for people, when they start taking a new medication, they see it as a signal that they are not doing as well. For people with side effects, people taking medications, they will often say it's a daily reminder of their health. Coping with hospitalizations, surgeries, cath procedures, invasive and non-invasive imaging procedures, this living with health uncertainty. And I think many of us have also experienced that firsthand during the past 2 years of the pandemic. Dealing with medical emergencies, device implantation, ICD shock, advanced heart failure therapies, declining health status, and transition to end-of-life care. So these are health-related stressors, potential sources of health anxiety common to all adults with heart disease. But there are also some things that are more unique to those who have had pediatric onsets, heart conditions. They often have traumatic memories of pediatric hospitalizations, surgeries. There are stressors associated with being in pediatric ICUs. There's the loud sounds, the bright lights, separation from parents, so there can be difficulties with attachment. They often say that they actually have been told many times that they are a miracle and lucky to be alive, and they feel like a guinea pig going through the system. They often describe feeling different throughout their lives, so there's some unique experiences that their peers haven't had. There's a transition from pediatric to adult care, worry and overprotection from others, neurodevelopmental deficits, and again, challenges and stressors related to education, occupation, and family planning. So oftentimes as I see these lists, and even when I write them, I think, my goodness, we actually ask a lot of our patients. And we know that stressors can be acute or chronic and are often cumulative and interactive. And I joined Twitter last year. And so there's a lot of patient organizations that have really powerful messages. And this is one from the Zipper Sisters. And they say, CHD patients carry on, but they carry a lot of pain. The memories of the surgeries, procedures, pain, guilt, and frustration, they've been dismissed, overlooked, left out, and sometimes silenced. And they emphasize that not all scars can be seen. And I often say the best way to ask, to find out how any individual person is doing, patient or colleague, is actually just to ask them. And we want to avoid making any assumptions. So let's talk a bit about the transition from pediatric to adult care now. So one really quick definition. And again, we talk about transition because this is something unique to people with congenital heart disease or other forms of pediatric onset heart disease. The Society of Adolescent Medicine defined transition as a purposeful, planned process that addresses the medical, psychosocial, educational, vocational needs of adolescents and young adults with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare systems. And so transfer is an event, but transition is a process. And we actually see this as a 25-year process. So in childhood, we can start teaching little kids the names of their heart conditions. And at this time, we start working with parents and caregivers, and we want to orient them to the idea that their child with congenital heart disease will one day grow up to be an adult with congenital heart disease. We often begin a more structured approach to transition in adolescence. Then there's the time of transfer, and here in Canada, we have mandatory age of transfer at 18, which means that people aren't able to be seen in the pediatric hospital after their 18th birthday. In general, in the US, a flexible age of transfer is recommended between 18 to 21. But the idea of transition, so education, self-management skills, decision-making, also continues through transfer to adulthood. And I remember I once had a colleague who told me, she said, I've got this transition and transfer thing down pat. What I do is when they come to see me, I treat them like I would any other adult. And I think that that's probably not appropriate for our young adults. So when people are 18 to 25, we consider them to be in this cohort of people that we define as being in emerging adulthood. So they don't feel like kids. They don't quite feel like adults. They're starting to learn about decision-making and things like that. And so I think we want to afford them some special accommodations in young adulthood. And I see two main aims of transition. And the first is continuity of optimal healthcare across the lifespan. meaning we want to avoid lapses in care or being lost to follow-up. This isn't easy because it depends upon the patient being informed about the importance of lifelong healthcare. It means the patient agrees that it's important and worth any discomfort or inconveniences. And it also means that they are able to access it. And the second aim, the second component, involves the knowledge and self-management skills to assume maximal responsibility for healthcare management and to live as full and independent lives as possible. Again, we ask a lot of our patients. So here is some of the education, the information we want them to gain. And I put stars beside the two things that I think are absolutely most important. We want them to be able to name and describe the heart condition. And I often tell people, if you were to go on a ski trip or beach vacation and you end up breaking your ankle and you get to the hospital, we want you to be able to just tell the ED team what you have. The names of and ages of previous interventions. We want them to know about medication, symptoms that warrant immediate medical attention, long-term health expectations. And again, we really want to emphasize the importance of lifelong cardiac care beginning in adolescence. We also want them to be able to prepare for future healthcare needs, understand whether there are any unique considerations for them for education, career, contraception, family planning, as well as substance use. Again, we ask a lot of our young patients, and these are things we ask adolescents in addition to everything else that's going on in their adolescent lives. In terms of self-management skills, we want to help them learn how to speak independently with health providers, make medical decisions, schedule and attend medical appointments, adhere to the medication regimens, know when and how to access mental health services and emergency care, and understand health insurance. So these are a lot of extra learning points that we ask adolescents and young adults to assume. We have been talking about transition for decades. There was a consensus statement from the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians, American Society of Internal Medicine, published in 2002. The position paper for the Society of Adolescent Medicine, that's the definition I provided before, 2003. Here in Canada, we had a position statement published in 2007. So again, none of this is really new information. We have failed absolutely at implementation. So the American Academy of Pediatrics in 2011 said, after nearly a decade of effort, widespread implementation of health transition supports as a basic standard of high quality care has not been realized. And there is a huge difference between awareness and talking about it and to implementation. And that is true whether we talk about transition, whether we talk about psychological care of patients with congenital heart disease or any form of cardiovascular disease, whether we talk even about clinician well-being. Awareness is fine. It's an important first step, but until we move to the implementation phase, nothing is going to change for our patients. In congenital heart disease, our first scientific statement was published in 2011. And in that statement there, we acknowledged that the development of ideal transition programs is a laudable goal that may not be achievable in the current healthcare environment. So kind of set ourselves up for a bit of, be nice to do this, but we get probably won't happen. We actually just published an updated scientific statement. This was released a week or two ago. And again, we noted that since the 2011 statement, efforts have been made to include transition programming as part of pediatric congenital heart disease programs, but there remain significant challenges to successful implementation. And I talk to people around the US, around Canada, around the world, and our implementation, I would give a failing grade in most places. Definitely no higher than a D when we think internationally. So what are some of the challenges? A systematic review of 57 American studies, and this is not specifically related to congenital heart disease. This was all medical conditions. The commonly reported barriers had to do with relationships, and this is between patients and family members, between patients and the medical team, between parents, caregivers in the medical team. We know that in the pediatric setting, oftentimes there's really close attachment between patients, parents, and their pediatric providers. I've worked with many adults who are facing the end of their lives, and they'll often talk about what they want after they die. And they may be in their 30s, and they still talk about the fact that they would like people to donate money to the pediatric team. So they have a lifelong alignment and allegiance with pediatric teams. There can be issues related to access, insurance, beliefs, expectations, skills, efficacy, how ready they are to do it, knowledge about congenital heart disease and transition, and issues with psychological functioning. We know that lapses in care occur. So Heart ACHD was published, gosh, this is almost 10 years ago now. And they enrolled almost 1,000 patients from 12 centers, and they had them complete surveys about gaps and barriers to care. And 42% reported gaps in care of 3 years or longer, including a quarter with severe congenital heart disease. And these gaps typically occur around the age of 20, which is when we think about transitioning or transferring them to adult care. This is one of my favorite studies looking at retention and care. So this is from Quebec, and they looked at patients who were born in 1983 with congenital heart disease, who were diagnosed before the age of 6 and alive 22 years later. And they looked at outpatient cardiac follow-up as well as any contact with the healthcare system. And they found that only 39% had cardiology follow-up after they turned 18, even though most had some contact with the healthcare system. And this study is often cited to say, well, you know, the adult care system needs to do better. You know, we take good care of them in pediatrics, we refer them to you, and somehow they get lost on the way to your clinic. You need to do a better job of getting them in your clinic. But to me, this is the most powerful figure here from this study. So again, they started with 643 people, and the proportion in gray are the people who were retained in care. So we can see that between the ages of 6 to 12, we had lost 36% at that point. And the green at the top, percentage refers to people who were never seen ever again. And the blue bit means that they were not seen at that time, that age category, but were seen later. If we look at the 13 to 17-year-olds, less than half were seen by a cardiologist. And then we get down to 39% in the 18 to 22. And what this means is that if we wait until patients are 16 or 17 to start talking to them about the importance of lifelong care, we are too late. Why do lapses occur? Well, for a variety of reasons. Sometimes people feel well. They know about the importance of follow-up, but they feel well. Sometimes they don't know that follow-up is required. Maybe they were specifically told that follow-up was not required. Maybe they were discharged from pediatric care without identified follow-up at an adult facility. Sometimes people have a complete access for medical care, lack of insurance, and fearful of receiving bad news. So consistent messaging is absolutely essential. It is really confusing for patients and parents, caregivers, if they receive inconsistent messaging between different providers within the same program or between outpatient and inpatient settings. Transition and transfer should be presented as appropriate, natural, and positive. So, you know, oftentimes patients will say, my pediatric cardiologist really loved me. We got along so great. And when I left, he said, you know, I wish I could keep seeing you forever and didn't have to transfer you. So it's understandable to think that, but maybe something that shouldn't be expressed to the patients. And making a public commitment to the principles of transition can benefit everybody. People often talk about not having money to do transition, and I would say that hanging signs in clinics ought to be affordable to most places. So we can hang signs that say, beginning in adolescence, we transition our patients to become more responsible for their healthcare. It is our standard practice to speak with teenagers on their own for part of every clinic visit. Our patients graduate to adult care when they turn 18. And here are some other things that we often recommend thinking about improving transition and what we might incorporate in a transition program. Develop an educational checklist, prepare a written transition plan, provide clear expectations and a rationale for practice shifts, like speaking to youth on their own during clinic visits ahead of time. Consider transition events, educational events for patients and families. Provide positive reinforcements when you see any efforts toward patient education and self-management skills. Integrate mental health professionals. Encourage clinic booking staff to speak directly with patients. Incorporate a 2-visit approach, which means don't have it be the very last pediatric visit where we say, nice seeing you, next time you'll be going to the adult care. Give them an appointment notice. So we give patients and families the opportunity to ask questions and express appreciation. Incorporate neurodevelopmental and psychosocial information into the transfer letters sent to new adult providers. Provide a personalized transfer summary. And again, use language that celebrates transfer of care. And if all of these things, if your reaction is, my gosh, that's a lot we're asking, absolutely. And I realize that, and this is why it is actually really important and necessary to have resources directed toward transition if we want to make things better. And anything that we value and we prioritize typically does take dedicated resources. So let's shift gears now to the why and talk about the impact of psychosocial challenges on clinical outcomes. Well, first of all, as a psychologist, I should say that even if there was no impact whatsoever on medical outcomes, I still think that addressing and treating significant psychological distress is warranted. However, we do know that it is also associated with some pretty significant outcomes, including more primary care and hospital visits, more ED visits, hospitalizations, more high resource use, hospitalizations, and increased mortality risk. And let's look at a few of those studies. This is a study published from my Yuli Kim and colleagues in Pennsylvania. And they looked at resource use for ACHG surgery admissions in pediatric hospitals. They looked at ACHG surgical admissions over 3,000 from 42 hospitals. And they defined high resource use admissions as greater than the 90th percentile for hospital charges. These accounted for, by definition, 10% of admissions, yet 34% of charges. And the mortality rate was much higher for these high resource use admissions, which we would obviously expect, the more complex patients. What was interesting is in this multivariable analysis of risk factors for high resource utilization, depression had an odds ratio of 3.1 here. So again, there's something about depression looking at health outcomes, complexity. And by the way, I should add that it's only been in the past few years that we're looking at this in congenital heart disease. We have a very robust literature from acquired heart disease that depression and other psychological factors significantly impact outcomes. Sorry about that. Oh, here we go. Here, sorry, this is my reference is wrong here. Sorry about that. So this is the database. This study is from Israel, and they had a database of over 8,000 adults seen within one of their large healthcare insurance organizations who were first seen in 2017 to 2011. And they found 35% had a recorded diagnosis of depression or anxiety. People who were depressed were older, more likely to be female, more likely to have comorbidities. They had more primary care and cardiology clinic visits, more ED visits, more hospitalizations. And then this figure here was also associated with mortality. So the blue line is for patients who have no documented, no recorded history of depression or anxiety. That red burgundy bar is for people who had past diagnosis, and the green there, that's for people who had diagnosis during the study follow-up period, which averaged around 10 years. And so we can see here that the risk of death was significantly higher in those who had a past or current diagnosis of depression or anxiety as recorded in the medical chart. This is a study from England, and they had 6,000 patients from the Royal Brompton. And of these, 3.3% were on antidepressant therapy. And I'll come back to that percentage in a couple of minutes. Females were more likely than males to be taking antidepressants. Treated patients were more likely to be symptomatic, and they were older. Males taking antidepressant medication were more likely to miss follow-up appointments than untreated males, and there was no difference between treated and untreated females. And here, when we look at the survival curve here, we can see that patients, the dotted line in the top were patients who were not on antidepressant, and the bottom were patients who were taking antidepressants. Followed up for up to 14 years here, we could see that there was a significant mortality disadvantage for people who were depressed, and they're using antidepressant medications as a proxy for being depressed. And there was also no evidence. They really did a really nice job. They put a lot of effort in looking into this, but there was no evidence that excess mortality was directly related to antidepressant therapy, QT prolongation, or any malignant arrhythmias. What's interesting is when they stratified by gender, on the left is the entire cohort, and on the right we have the treated, and it really is males that had the negative outcomes. So there was something unique in this study about men who were depressed, who were on antidepressant medication. They are the ones that had much, much worse survival outcomes. And finally, this is a study from the US, and they have a Boston ACHD biobank study, and they have 11,046 people enrolled in that study. 219, 19 or 20% had depression. And in this figure here, the red dotted line is that 19% figure of the ACHD population who had depression. That broken up blue line there is what we would expect, or what they would expect in the general population. We can see that rates of depression in this database. So, and they did this by looking at clinical records. So again, it's a database study. People who are depressed more likely to be female, to have low O2 sat, more likely to have functional impairment as reported by NYHA class. And what's interesting at the bottom is we see that severe and mild had higher rates than moderate. We often see a nonlinear relationship. So that's a bit interesting there. And here, by the way, in this American sample, 18% of the total sample were taking antidepressant medication. Much lower, less than 10% of people who were not identified as depressed, but 69 of those who were identified as depressed. And it's interesting how the rates in the British sample were 3.3%, and here we have 18%. So there's something a bit different about prescribing on both sides of the pond. And here again, we find the same thing. So the red line is patients with no depression. The blue line is patients with depression, and significant all-cause mortality outcomes between the two groups. So we know that being depressed or anxious have consequences for outcomes. We also know that lapses in congenital heart disease care can have outcomes. And there have been a series of studies looking at what happens when people eventually present to care after lapses. Well, they tend to be more symptomatic, not have an appropriate medication regimen, not have received optimal Medicare. They get extra diagnosis, they require urgent diagnostic testing, and they often require urgent cardiac intervention. So I would say that for the quality of life and the psychological well-being of our patients. We want to help. We want to manage their needs, treat as appropriate. And we also really want to focus on how can we help them retaining care, because we want them to have the best possible medical outcomes. And these things take a team approach. So let's switch gears now to the how and talk about strategies to improve the psychosocial well-being of adults with congenital heart disease and other forms within a team-based approach. So a list of some general strategies here. I often say that you don't have to be a psychologist or a mental health professional to improve mental health outcomes. And this is why today I'd like to share strategies that we can all consider. Sorry. We want to encourage medically appropriate physical activity, which has mental health benefits in addition to physiological benefits. Encourage activity pacing, which means not overdoing it on good days. We want to make sure that people are not avoiding preferred activities out of fear rather than due to medical advice. So I often say, let's ask if people are avoiding anything and make sure that they're doing so appropriately and not just because they're afraid of what would happen. Encourage planned participation in pleasant activities. Offer positive verbal reinforcement when people tell you that they're doing things that are helping themselves. Provide opportunities to connect with other patients. Offer patient education days and refer to mental or behavioral health professionals as appropriate. I strongly advocate for an integrated approach whereby psychologists, psychiatrists, counselors, licensed clinical social workers are fully embedded within cardiovascular teams, and this has advantages for patients. There is the destigmatization of mental health issues by patients and providers. There's improved access, they get specialized care, and they get the benefit of true interdisciplinary care. Members of the cardiology team have the option and opportunities for consultation. So maybe they want to ask a question about how to manage a patient concern. There's increased confidence opening that discussion. So it's much easier to say, you seem a bit anxious, or, how are you doing these days? What's your quality of life like? Are you experiencing any significant psychological distress? Much easier to ask that question when you know that you have somebody you can refer them to. Cardiologists, it gives them the opportunity to improve patients' quality of life. So, which I often contributes to a sense of provider well-being. And there are opportunities for collaboration in education and research. And as a psychologist, as a mental health provider, I like having access to complete medical details. I like being able to consult if I'm trying to figure out whether a symptom is related to anxiety, for example, or their cardiac etiology. I get to ask. I like having well-trained referring providers who can triage referrals. And again, we can contribute to interdisciplinary education and research. I created a couple of years ago this list of prompts for referral to mental health professional. And these are reasons why I think it's helpful to have somebody embedded and fully integrated within the cardiology team, because these are things that a community mental health professional might not know about. So congenital heart disease contributing to anxiety or depressed mood, heart-focused anxiety, difficulty coping, difficulty with the transition, difficulty with adherence, challenges communicating effectively with healthcare providers, body image concerns, challenges about social relationships, need for support with decision-making related to cardiovascular care, difficulty adjusting to devices, prepping for surgery or cath, significant change in cognitive functioning, and concerns regarding future health expectations. So again, these are things that somebody integrated in your team might be able to help with. So what are some communication strategies now? And this is where I will end. So these are strategies that I think can improve the psychological well-being of adults with all forms of cardiovascular disease. And I should say that my goal in today's presentation is that maybe people leave with one thing, one statement, one question that they may do do a little better. So my goal is to help people feel a little more confident with their patient communication, with the idea of promoting psychological well-being. So first of all, ask follow-up questions when a patient tells you that they are anxious. So we don't want to assume. If a patient tells you that they are anxious about surgery, let's not assume it's that they are anxious about outcomes. For some of them, it may be they're worried about the pain, or they're worried about being away from their family, or they're worried about losing their job, or they're worried about their pet being alone. So anytime somebody says, I'm really anxious, ask them what it is that's making them anxious. Provide realistic expectations. So rather than saying, for example, I'm going to call you the day after with your test to discuss your test results, it's actually better to say, within a few days after, I will give you a call. Otherwise, people are sitting worrying at home. Ask how patients like to receive information, lots of details or big picture. When I work with patients who like lots of details, if they only get a big picture, they think you're leaving something out. When I work with patients who only want the big picture, when you give them a lot of details, that can stress them out. So ask how much information they like. Tell people before you do something to their body. This is something that has come up more and more in recent years from conversations with patients. And they say, suddenly somebody touches them, or they start poking and prodding, and they say, I realize it is appropriate and they need to do that to get some information, but it goes a long way when we tell them that we're going to do something like that. Acknowledge vulnerability, for example, a hospital gown. And I have a colleague in Scotland, actually, who wrote a really nice paper at this. And she actually is a psychologist who has congenital heart disease. And, you know, in adolescence and adulthood, we remove their dignity in the hospital setting. So it's important to acknowledge that. Be mindful that masks remove the ability to read facial expressions. So during the pandemic, I actually preferred virtual therapy because we could see one another's facial expressions. So just be aware that sometimes it's good to convey your expression, your mood, and also ask how they are doing. And it's important to acknowledge psychological distress, but don't let it dictate diagnosis or treatment. So don't say, well, anxiety is the reason that this patient is having all of these symptoms, because patients often feel they are dismissed when they do have a psychiatric diagnosis. Here are some statements that I recommend. Many of our patients struggle with low mood or anxiety at some point in their lives. We understand that living with heart disease can affect more than a person's heart. It can affect a person and their family in many ways. It is understandable that your health history would have an emotional impact. Even patients who are strong, independent, and resilient sometimes struggle with emotions. Please let me know if you're struggling with low mood or anxiety now or in the future. Things can change over time. Instead of asking, I'm a fan of language tweaks. Instead of asking, do you have any questions or concerns, which is a yes or no answer, ask, what are your questions and concerns? Instead of saying, do you understand this information, say, am I explaining this clearly? If a patient doesn't understand something that I have said, it's not their job to listen better. It's my job to explain things more clearly. Let's avoid saying, don't worry about this, because I'm sure many of us have been told, don't worry about this, and it never works. So instead try saying, I understand this can be a scary situation. It's understandable that a person would be concerned about this. As a cardiologist or nurse, this doesn't alarm me. So choose different words other than saying, don't worry about this. Keep in mind that what is routine for you is not routine for patients. So empathy goes a long way. Instead of saying, I do this all the time, try saying, I have a lot of experience with this procedure, but I realize this might be the first time for you. Instead of ignoring or dismissing when a patient references a previous negative health experience, say this, Tell me what we can do to ensure a better experience this time around. Instead of saying, I know how you feel, because we never know what other people are feeling, try saying, I've heard from other patients that, ... I can imagine how difficult this is for you. And so important, just tell me what this is like for you. I'm a big fan of, I have a low threshold for calling out resilience when I see it. People often go to their doctors and their nurses, and they expect bad news. They're looking to get negative information about their health. Call out things that you see well. I really admire how I get that things are so difficult. I'm really impressed that you managed to get here for clinic today. I know we had discussed having a regular exercise regimen. I know we discussed trying for 5 days a week, but you've been getting 1 or 2 in. I'm really impressed that you have been doing that. So look out and see the good, because patients remember that. So the littlest thing you say, words of encouragement, they come and tell me after, and they say, my cardiologist said that they were proud of me, and that really meant a lot. So in conclusion, adults with congenital heart disease do face unique psychosocial stressors, and those are in addition to those faced by their healthy peers, and in addition to those faced by adults with acquired heart disease. And they face these unique challenges across the lifespan. It is thus completely understandable that they have an elevated risk of depression and anxiety. And in fact, psychiatric disorders are likely the most common comorbidity, and they largely go untreated. So it's time to move from awareness to implementation. Our responsibility to patients with congenital heart disease extends beyond saving their lives, and we have a collective responsibility. I don't see this as something just nice to do. It is our responsibility and our opportunity to help patients achieve the best possible psychological outcomes and quality of life, and to live as full and independent lives as possible. And thank you very much. And I'm going to stop sharing my screen.
Dr. Kovacs, thank you. Thank you very much. That was incredibly informative, and I love the practical tips in the end about how to phrase things in a different way. Very helpful. I have a question. This is a lot to ask from us too.
Yes.
I mean, this is I love our congenital heart disease patients. I love them, but taking care of them is exhausting. And I mean that in the best sense, and the best meaning possible, simply because we care about them so much. But to add more, for us to be now even more responsible for their psychological well-being is a lot to ask. It's important. I think it's necessary. Do you have how do we make the time or the emotional bandwidth even to make that happen?
Yeah, so I think that is an excellent point, and I'm going to say I agree with you 100%. And I would say that I've worked with people with all different areas. I work with a lot of different cardiologists, and absolutely the people who work with congenital heart disease have the patients who often require the most time in clinic. And you're talking about other things too. So the basic clinical exam takes a lot there. This is why I don't think you ought to be doing it all on your own at all. I think we ought to create an environment where you can ask some of these questions. I think we need psychologists and other mental health professionals integrated within teams. We can't do better without that. So when I talk about a team approach, it is what can the cardiologists, the nurses do to introduce the dialogue? Because I see this almost being, when a patient comes to clinic, you might think they're coming for a routine visit, and you go through the things that you would generally go through on their annual review, or their every 6 month or every 2-year review. And sometimes they show up as something that was unexpected. So it might be heart failure, it might be an arrhythmia, and you deal with that extra add-on thing as it happens. I think that psychological distress is something like that, that we want to be prepared for when we see it. And we need to give you resources to deal with it better. We need you to be able to say, you know what, we understand this. And for you to be able to say, this is not my area of expertise. So, I joke and I say, I'm a psychologist. I know a lot about congenital cardiology, but you're not going to come to me for your congenital cardiology care. We want, I think, the cardiologist to know a bit about psychological outcomes and to be able to say, it seems like you're going through a lot right now. This is something, that not my area of expertise. I care about you a lot. So we have somebody that we're going to refer you to. And I will say that things are not going to get better until cardiovascular programs and cardiovascular organizations prioritize this. And I say this, I first started in 2004 in a staff position. And I say this, things have not changed tremendously, which is why I think I often say I've earned the right to be feisty about this, because patients are advocating for this. When you talk to patients, this is what they want. It will take cardiovascular programs, organizations to say, we prioritize this, and absolutely to make this happen. When we look at accreditation criteria for ACHD programs, they have something that says you need to have access to mental health care. They have not said thus far that you need to have a person as part of your team. I think it ought to become mandated, because oftentimes things don't change unless we have to do it. So I would say that I hear you, I empathize, and I think we definitely need a team approach, and we need mental health providers integrated within teams. I don't want you to do it all on your own at all. I realize how busy you are. So I think starting the dialogue, I hope, is there. And sometimes you can do things to ward things off. So when somebody says, I'm worried, if you say, what are you worried about? And they say, well, I'm worried this will happen. Sometimes you can say, well, that's not going to happen. But for the heavy stuff, I don't think we should ask you to deal with it. Not at all. Wendy, Dr. Brooke?
Your book.
Yeah, real quickly, I know we're almost out of time. Are there resources available in the short term that patients can access? As you know, mental health care is not uniformly available across the United States. We happen to reside in a state in which mental health care access is particularly limited. Are there any national resources for these patients to access care?
The Adult Congenital Heart Association is the patient organization in the US. They have a peer-to-peer support program where you can get they have trained peer counselors, if you will, to talk to patients about things. But there are, other than, attending conferences and presentation, there are very few national resources. And I lived previously in Oregon, which is one of the worst states in the country in terms of availability of mental health professionals. So, there are websites, there are apps and things like that, but I would say not great resources nationally, unfortunately. Yeah, it is a tricky situation. And again, I think that because we don't have the community providers, this again is a reason why I think integrating mental health professionals within cardiovascular teams is the way to go, especially because they can bill. So psychologists, psychiatrists can bill for services also, but I do not see things improving until we have integrated care. And you're not the only, I don't know what the situation is like at Emory. Very few places have this. And then one other thing I would if I can just add on that note, we wouldn't dream of building a world-class cancer center without including psychosocial oncology and palliative care. I think our cardiovascular patients deserve the same level of mental health care.
Dr. Kovacs, thank you so much for talking to us about this and for enlightening us on this very important topic.
Thank you very much, everybody. Have a good day.
You too.
The preceding program is copyrighted by Emory University.